I'll just briefly introduce Dr. Rajesh Puri. He is a consultant gastroenterologist and interventional endoscopist at Medanta Medicity, Delhi, Gurgaon. And his main area of interest is endoscopic ultrasound and related procedures.
So good afternoon, everyone. Would like to thank for inviting me, Dr. Sanjay. And I will present my presentation in a very short period of the time. And in the previous talk, it was nicely discussed, the management of the patient should always be multidisciplinary, rather than saying that the endoscopy is the treatment or the surgery is the treatment. The most important is the patient is in the center, and we should talk in benefit of the patient. And in the last 30 years, you have evolved from the open surgery to the laparoscopic surgery to a robotic surgery to minimally invasive endoscopy. And endoscopy is no more like an upper GI and colon. It has moved to a minimally invasive surgery. And the recent advances has been in the form of to see the better. And better means the magnification has gone up to the tune of 240 or 520. We can see the surface and mucosal pattern, and we can diagnose the malignancy very early, and we can see the microscopic detail. To visualize the area which is not seen, like small intestine, bile duct and the pancreatic duct, to look outside the gut wall with an endoscopic ultrasound. So most of you have seen this endoscopic images, but if you see now, with a magnification endoscope, a better surface pattern, better vascular pattern, we can diagnose the early cancer. And once you diagnose the early cancer, it is a high success rate for the treatment of malignancy. Similarly, this is a video now endoscope with the 520 magnification, meaning that you can examine the microscopic nature of the lesion, and you can plan, are you dealing with the hyperplastic polyp or adenomatous polyp or a malignancy, and what is the depth of malignancy. That is going to decide what should be the treatment. Now regarding the small bowel, we have done yesterday, you have heard about the double balloon enteroscopy, 2 balloon, and you can see the entire small intestine. Similarly, it can be done from the antegrade route as well as from the retrograde route. Recently, we have a spiral enteroscope. And what is the difference? In a single balloon and the double balloon, it is a too much burden on endoscopy, and it's going to take around 1 to 1.5 hours, and it requires an antegrade and the retrograde route. But with a spiral, there is a machine attached on the shaft of the scope, and the machine works. Doctor has to just put a foot on the switch pedal as you are driving the car, and within 40 minutes you are going to scan from mouth to the ileocecal area. So the area which was not visible can be examined without any exert on endoscopies. The second advantage is it has a large therapeutic channel, so polypectomy, APC, or you can do the clipping of the lesions. Capsule endoscopy, this is a minimally invasive technique, which is a capsule of 11 into 22 millimeters, swallow with the water. Over a period of the 8 hours, it gives 60,000 photographs of the small intestine. So those patients who are not fit because of the cardiorespiratory problem, you can see the capsule endoscopy and you are able to give the diagnosis. These are the few images. Now about the bile duct, we have a thin cholangioscope which goes from an ERCP scope. They are called as a baby scope, which goes through the therapeutic channel of the ERCP scope. And you go inside the bile duct, you can look at the stricture. Earlier there was a problem, are you dealing with the benign stricture or malignant? You can do the targeted biopsies and you can give the diagnosis, and that helps in the management of the patient. Another important advantage is, now there is no stone which is left by an endoscopist. Earlier, people used to talk stone more than 2 centimeter require a lab CBD exploration, but now a stone of 3 centimeter can be crushed with the laser lithotripsy, and you can give the CBD clearance in more than 99% of the cases. So these are the advances which has happened. A few words about the endoscopic ultrasound. The difference from the CT and MRI, it gives the 5 pattern layer of the gut wall. So for the T staging of the cancer, this is a very good modality. For the subepithelial lesion from which layer it is originating, you can find out this patient can be treated with endoscopy or with the surgery. The most common indication is a mediastinal lymph node for the physicians, where we can take the FNAC as well as we can take the biopsies also. So mediastinal lymphadenopathy of any origin, either it is a tuberculosis, sarcoidosis, metastasis or lymphoma, we can give both cytological as well as histological diagnosis. Similarly, a node of 5 millimeter. The size is not important. Even a node of 5 millimeter can be taken with the help of EUS guided. The diagnostic accuracy of EUS guided FNAC from the periluminal lymph node is more than 95%. Now, for the staging of the staging of the GI gut cancer, esophagus, stomach, as I told, for the T staging, this is the only modality which is available. When we talk about the pancreatic fluid collections, we have discussed in the Mohan paper, somebody was talking about endoscopy versus percutaneous. This is going to take 4 minutes. So any periluminal collection, which is a wall of necrosis, you can do with the help of endoscopic ultrasound, and you can do the drainage of the wall of pancreatic necrosis. It's a daycare procedure, no scar, no external drain on the patient. Similarly, EUS guided gallbladder drainage or the gastrojejunostomy, especially those patients are sick. I'm not saying all patients should go for the gallbladder drainage. It should be done by surgery, but in a patient who is in ICU, cannot be done, and patient don't require a percutaneous drain, or gastrojejunostomy is an invasive procedure. With the help of endoscopy, again we have a lumen opposing stent, and which is going to take 8 to 10 minutes, and you can do the EUS guided gastrojejunostomy, especially those patients who has an advanced malignancy. Earlier you have heard about the biliary drainage with the help of ERCP, but because of any reason, either you are not able to cannulate, or papilla is not accessible either because of gastric outlet obstruction or because of altered anatomy, you can do the EUS guided biliary drainage. It can be done from the duodenum, it can be done from the stomach through the transhepatic route. So this is one of the example. Patient has a gastric outlet obstruction. We changed the scope from ERCP to EUS, and it shows it was done the choledochoduodenostomy. If patient has an altered anatomy, you can do the hepaticogastrostomy also. So the biliary drainage is also a good option. Patient who is terminally sick, has a pain in a patient of upper GI cancers, has a significant pain, not responding with the analgesia. Earlier we do a radiological guidance celiac plexus block, but here under visual guidance you can do the celiac plexus neurolysis. Over the scope, our clips are available for the massive bleed, or endoscopically induced perforation. You can do the closure of this, so you hardly require the surgical intervention. We have a third space endoscopy. Yesterday we did the 3 procedure, that is POEM. Earlier it was required a surgical. With the help of POEM procedure, you can do this procedure within half an hour to 40 minutes, and it has a good rewarding to the patients, and the accuracy is up to the tune of 95%, as good as surgery. So this is the circular myotomy and the longitudinal myotomy you are doing, and once you do the myotomy, you can close the defect from where you have done. So this is the clip closer from where you have done the entry. So third space endoscopy, especially for the subepithelial lesion, motility disorder, it is a good technique. Now we have a full thickness device also. We can do the full thickness resections. So this is a neuroendocrine tumor or T2 or T3 stage of the disease, which is patient cannot be go for the surgery. We have a full thickness device. It gives from serosa to serosa complete resection and the closure during the same time. So risk of perforation is also very less. Endoscopic bariatric procedure, as well as for the diabetes control, we have a various balloons which is available. These balloons are refill balloon or they are swallowable balloon with a different company makes. They are useful especially in the patient who has a BMI of 25 to 35. Same for the GERD, we have got a arms GERDEX. Patient who has a Hills grade 1 and 2, you can do the endoscopic treatment of the reflux disease. So thank you for the patient's hearing, and I invite everyone for the next month. We are doing a therapeutic interventional conference for the pancreatobiliary. If anybody is keen, they can join us. Thank you.
That was wonderful, and in fact that is almost like a glimpse of what all procedure we did yesterday. So this is what endoscopy is in today's era.
So sorry, in the 10 minutes I have given, each topic has a separate talk, but definitely therapeutic endoscopy has evolved right from upper GI colon to the minimally invasive surgery. We are doing the therapeutic endoscopic procedure, treatment of cancer, biliary drainage, pancreatic duct drainage, third space endoscopy. Thank you.